Dr. Qian Lu is a professor in the Department of Health Disparity Research at the University of Texas MD Anderson Cancer Center. So she's going to give a very unique presentation. Dr. Lu has developed innovative psychosocial interventions for underserved populations. She is a pioneer in Asian American cancer survivor research. So I know this afternoon we're going to have a very educational and learning opportunity. So without further ado, let's welcome our first presenter, Jia Li.
Very nice to meet everyone here. And then just like, the very nice introduction. Actually, I'm a
for our national level, and that is bridging the digital divide in the NHPI community, ensuring that our community is digitally literate to their fullest extent and also have access to home internet and devices. Second is intergenerational well-being, which is really new to OCA, but that's because we identified that in the intergenerational well-being category, mental health and caregiving were two issues that impact our community that weren't getting enough support federally, state-wise, in policy, but also in community education. And third is voting rights. And at the state level, our policy platform consists of protecting voting rights, protecting Asia Town and fighting gentrification, cultural preservation, K through 12 curriculum, ANHPI curriculum in K through 12 schools, and fighting anti-Asian hate. So that's our policy work that we do, and our programming work works in tandem with that. We do youth programs for high school, college youth. We do professional development programs for working professionals just out of school through almost retiree age. We do mentoring, career development, API history education, and API identity education, because that's a huge missing factor in, again, K through 12 schools, college education, and even in the workforce, right? It's very important for folks to be able to develop and understand their API identity to be their fullest selves in whatever it is that they're doing, whether that's school or at work. And we do that programming at the national level, as well as all of our chapters. So I actually came out of our OCA Greater Houston chapter here, and now I work at the National Center. So related to mental health and what some of the things that the summit had brought me here to talk about was what we've witnessed in regards to the anti-Asian hate pandemic that happened starting in 2020 and continues today. OCA's role in the Stop API hate movement has mostly been legislatively working with the Department of Justice to pass legislation or pass policies and practices in law enforcement. But one of the things that we've continuously had to uplift is the lack of in-language resources for our community and in-language outreach and the impact that the waves of anti-Asian hate on mental health in our community. What our community didn't know either was that the Department of Justice and their state and local offices do provide resources and support to address mental health. And that was never something that our community knew about. And so those are the kinds of things that we worked with government to address. And in terms of our various chapters across the country, even though API communities differ across the country, something that we saw in common across geographic differences was the level of tension and conflict regarding community safety and weapon usage, gun ownership specifically, within the ANHPI community. So then we were having discussions within OCA of how do we educate our own community on gun safety and also solidarity, because we didn't want to see another Koreatown LA riots happen where our community was not in solidarity with other communities of color and aiming weapons at each other. And so that's another example of, you know, in the 2020 wave of anti-Asian hate throughout the Black Lives Matter movement, the kinds of mental well-being and tensions that were impacting our community that OCA was not only addressing like legislatively, but also as a community education resource. I would say that as we are actually developing our intergenerational well-being platform right now, we're trying to identify what are the top issues that impact our community policy-wise, right? And right now what we've identified is just the lack of language access in terms of mental health care and cultural competent access to care, where youth on college campuses are not receiving culturally competent counseling and therapy provided by their school campuses, where, you know, an emergency crisis counselor at a university campus may not understand our Asian American youth in terms of why they may be failing classes, and if it's a class that they are not necessarily excelling in, but there's an underlying reason why they may be taking that class. Counselors aren't necessarily, they don't have the cultural competency to ask certain questions, like perhaps what are the decisions into taking this class, right? And it comes from, oh, actually, this is what my parents want me to do. And sometimes the response from that is, well, why don't we just take what you want to do? But that's not necessarily the answer that they're looking for. And that's the cultural competency that is lacking. And we're trying to figure out what are ways that we can help the medical field kind of mandate and look into cultural competency training for providers, right? The last thing, actually, I think that's kind of it right now that I'll share. Pass it on to Joe.
That's quite broad. Thanks, Tim. Okay, Joe, you're up.
Oh, you're muted. Oh, she's muted. Yeah. Can she... Oh, there you go.
Yeah. Here we go.
Here we go. Yeah, sorry about that.
Oh, that's great. Thanks, Joe.
All right. So I'm very happy and honored to be here. So today I'm going to talk about facing adversity, the impact of anti-Asian racism and the COVID-19 pandemic on Asian college students and Asian medical trainees. So I have no relevant disclosures. I want to start with some background about hate incidents So the Stop AAPI Hate reports since the pandemic started, over 11,000 hate incidents were reported between March 2020 to March 2022, over 2-year period of time. And about half of the incidents occurred during the peak year of 2020, and harassment was a major problem. Almost 1/3 of parents reported they were concerned about their child being a victim of anti-AAPI hate or discrimination in under-supervised spaces and on the way to school, so which is a serious public concern. And then before I move on to talk about more key findings from the Stop AAPI Hate, I want to say a few words about Stop AAPI Hate, which is a US-based coalition dedicated to ending racism and discrimination against AAPIs. As the nation's largest reporting center tracking anti-AAPI hate acts, the coalition publishes data, insights, and research findings as it is experienced by our community. So the report findings included the following data I summarized here. So Asian Americans who have experienced racism are more stressed by anti-Asian hate than the pandemic itself. 1 out of 5 Asian Americans who have experienced racism display racial trauma. Asian Americans who have experienced racism have heightened symptoms of psychological and physical symptoms. Experience of racism during the pandemic is found to be more strongly associated with PTSD symptoms more than those who do not have the experience. So background, I want to further the background by talking about the trends in discrimination. So again, from the report, the youth were found to be more likely than adults to be harassed at school. You see the numbers is quite different for the youth and adults, and also more severe online. And the girls have 2.5 times more likely to report than the boys. Adults were present in almost half of the anti-Asian cases, but alarmingly, bystanders intervened in only 10% of those cases. And the intersectionality of gender, I want to mention specifically women are more often the victims of violence. 1 out of 3 women had experience of physical violence from intimate partner. 1 out of 4 women had severe physical violence. 1 out of 5 women experienced sexual violence. And women students are often victims of violence. And specifically, women in medical training, they are about 60% of medical students and trainees have experienced harassment in training. And note, there are more women reported than men. So hate has a significant impact on mental health among Asian American individuals who experienced a hate incident reported to Stop AAPI Hate. Almost 3/4 named discrimination against them as their greatest source of stress, even ahead of their health concern from the pandemic itself. And a half of Asian American and Pacific Islanders experiencing discrimination reported feeling sadness, stressed out, anxious, and other emotional outcomes. So during the pandemic, AAPI youth have been severely emotionally impacted and reported anger, frustration, disappointment, fear, sadness, and depression. During the pandemic, this study showed that younger adults and racial ethnic minorities have reported disproportionately worse mental health, increased substance use, and elevated suicidal ideation. So a recent review study indicates that burnout and mental health concerns about 30 to 60% of physicians and residents. So residency training was shown to create the highest rates of burnouts and as well as high rates of depression disorders and depressive symptoms. So health workers during the pandemic have also reported an increase in mental health issues. This is the NCES report, so stands for National Center for Education Statistics, is the primary federal entity for collecting and analyzing data related to education. So per May 2022 NCES report, there are roughly 3/4 of schools reported an increase in staff voicing concerns about their students showing symptoms of depression, anxiety, and trauma. And 69% of public schools reported an increase in the percentage of their students seeking mental health services at school. A large-scale survey study looking into the impact of COVID-19 on college student well-being, and the collected data from late March through May of 2020, and found that 60% of college students reported lack of easily accessible mental health care. So another large sample survey study assessing mental health disparities, which was published in 2018 prior to the pandemic, and they recruited more than 43,000 of college students of color, and found among those with a mental health problem, Asian students had the lowest prevalence of treatment, with roughly 80% of cases being untreated and 23% experienced perceived stigma. So this is data from SAMHSA. So this is the table showing any mental illness in the past year among adults. And I specifically chose to show you the data from 2019, which is prior to the pandemic, and 2020, which is the peak time of the pandemic. So note the age group of 18 to 25 here, that showed in this age group, the mental illness numbers are significant. Most importantly, I want to point out here in this slide. So some good news is that younger adults in this age group of 18 to 25 were actually receiving more mental health services. So if we look at the 2020 data to compare to the 2019 data, which is increasing. However, looking at the Asian Americans, it is the only group had a decreased utilization of mental health care services, so which is alarming, right, from the contrast of the data. So next, I want to talk about our two studies. So study number one, we did look at COVID-19's impact on discrimination and racism experienced by Asian medical trainees. So the aims were to evaluate differences in rates of anti-Asian discrimination in Asian medical trainees before and after the pandemic started, and also to compare the socio-demographic correlates of anti-Asian discrimination experiences to describe the different types of discrimination and compare the level of community and institutional support. So the study design was cross-sectional web-based survey, and the responses were recorded on 5-point Likert scale and in the form of yes/no questions. There were no open-ended questions. So the data was collected during the months of November 2021, remained open for 4 weeks. And the seclusion criteria for the study is self-identified Asian adult medical trainees currently training in the United States. So the study survey questions included demographic information, experience of racism, including prior to the pandemic for about 12 months time, and since the pandemic started. So we asked the respondents to recall those information and the setting in which racism occurred and the racism's impact, including overall impact, functional impairment, which, as we know, especially to our mental health providers, it's a very, very important indicator, and impact on training, change in behavior. So additionally, we collected data on need for mental health care due to racism and support received from family, peers, community, and institution. So for the final analysis, we included 399 participants' data for the final analysis. In terms of gender distribution, a large proportion of the participants were women, consistent, but slightly higher than the Association of American Medical Colleges data from 2020 to 2024, ranging from 51% to 55% with upward trend annually. And regarding the sexual orientation distribution, 71% were reported to be heterosexual, followed by 15% non-heterosexual and 14% identified as others. Around a little over a quarter were first or second year medical students, followed closely by 26% third or fourth year medical students. 20% were residents, 9% were fellows. The most populated training region being the West, which was a little over 1/3 of the participants, followed by 29% of the participants were training in the Northeast, 17% in the South, and 6% in the Midwest. Regarding the ethnic distribution, 61% were of Southeast Asian descent, and 24% were East Asian, 14% were West Asian, and 8% were multiracial. 66% were born in the US, highly consistent with the national representative study that found the proportion of non-US born physicians to be 29% among the total physician pool in the US. So we also did some statistical analysis and found there was a significant increase compared to before the pandemic and since the pandemic started. So increase in the incidence of microaggressions, harassment, stress, and violence. And a great proportion of participants suffered the impact of anti-aging violence during the pandemic period compared to before. A great proportion of participants experienced functional impairment due to anti-aging violence. They expressed of concern about their family becoming a victim of the anti-aging violence. About 1/3 had a great deal, a lot of concern. 28% reported moderate concern. Almost half, 44% of the participants endorsed changing in their behavior in response to the anti-aging violence. So further, the data show that 17% of the participants were either considering seeking or were seeking mental health care due to the pandemic-related anti-aging violence. Note this number is quite low. 44% of the participants reported that their training institutions' adequacy to the support of adequacy to anti-aging violence was far short or short of expectations. So the proportion of participants who received a great deal or a lot of support reported the majority of the report were from their family, peers, community, only 6% from their institutions. So from the results, we can see the study participants endorse being impacted by the anti-Asian discrimination during the pandemic and having resultant functional impairment behavior change, but did not have clear impact on the training. Maybe some long-term tracking data would show on that perspective, but we don't have that data in our study. Most of the participants felt supported by their family, peers, and community, but not sufficiently by their training institution. And also, the support they felt was from the institutional support was short of expectations. So I want to follow with our study number 2. Yes,
Joe,
Dr.
5 minutes. 5 minutes.
Okay, all right. So study number 2, I want to talk about the impacts of COVID-19 on AA-NHPI college students. So for the sake of time, I'll skip this one, which is similar to the previous study. Study design also similar. We collected data from February to March of 2023. And we collected the data on demographic mental health data, including PHQ-9, which is for depression symptoms, GAD-7 for anxiety symptoms, substance use question, and a brief perceived ethnic discrimination questionnaire, community version, also civic engagement and access to mental health services. So we included participants. Did I hear a comment? No.
No, go ahead. Keep going.
Okay, all right. So security criteria was self-identified NHPI adult college students at the time training in the United States. So here I have some data. So we included 1,006 participants data in the final analysis. So slightly more than half participants were female, predominantly heterosexual in terms of a sexual orientation. And around 1/3 of participants were of East Asian descent, followed by Southeast Asian, South Asian. As for native language, other than English being the majority, note this is consistent with the data showing that 70% of participants were born in the United States. So the table here shows that the Indian being the top language, which is Hindi plus Indian dialects, followed by Chinese. So university region and undergraduate year, I'll skip you can visualize those data pretty easily. For the substance use question, so we mentioned previously that literature showed that the substance use had increased during the pandemic among younger adults and racial ethnic minorities. This was also reflected by our results. So we asked one single question in this survey. So during the pandemic, have you started or increased substance use to cope with pandemic-related stress or emotions? So about 20% of participants answered yes. So this number may sound not alarmingly high, but note this question was about the change in the substance use behavior. So do not include people who have not changed their substance use status as they had been using prior to the pandemic. So also some preliminary findings. Alarmingly, about 3/4 of participants reported at least mild anxiety or depression symptoms. So in the survey, we asked the participants if they perceived COVID-19 and or racism as contributors to their depressive and anxiety symptoms, as those the pandemic itself and the racism are intertwined and expected sometimes possibly to be hard to differentiate from participants' response perspective. But the further statistical analysis showed that the brief perceived ethnic discrimination questionnaire scores were correlated to both PHQ-9 and GAD-7. So we know that at least the perceived discrimination played a stand-alone role aside from the pandemic itself to the participants' anxiety or depression symptoms. So I want to conclude here by acknowledging our funding resources and also to our wonderful team of especially the students and the trainees on the team. It is very exciting to see our next generation of scholars and healthcare providers interested in this important work. So I have a few more slides, but I'll stop here because there are resources, and later on I can share the slides. So thanks all for your attention. I think I'm going to move on. Dr. Shen, move on to the next speaker.
Sounds good. Yep. Yeah. So thanks for sharing with us the results from your two studies. And next, we'll turn the floor over to Anu.
Yeah. Hi, everyone. My name is Anam. I am South Asian. I am from Pakistan originally. My parents are from India. So the work that I do with Nunchi Health actually is fairly new organization in itself. It's founded at Harvard Medical School. And our focus is to provide mental health services to immigrant origin youth. So we do a lot of work at campuses and universities. We pair students with clinicians who may be able to guide them, support them. So it's not a therapeutic work per se, but the fellowship actually focuses on understanding what their needs are so we can actually collaborate and create support for them that is most beneficial to them. So understanding their stories, their narratives, what are some struggles that they're facing right now on their campuses. So for example, the situation right now with Israel and Palestine, so we're trying to understand what would be most helpful to the students that are going to these schools and are, facing hate crimes and things like that. Other than that, I also am part of the South Asian Ismaili Muslim community here in the greater Houston area. So we focus on providing mental health first aid trainings to individuals and faith leaders, because I do believe, at least in that setting, it starts with the faith leaders to bring them on board and to destigmatize mental health. So the trainings focus on understanding the symptoms, the triggers, the challenges, and how to provide support and what does support look like to begin with. So that training in itself is provided in different languages. So Hindi, Urdu, Gujarati, English. So those are the main languages that we focus on with that community. So I'm kind of doing that work with Nunchi Health that I mentioned and this, but lately I've also been interested in understanding parental decision-making around social media use of their children. So right now my focus is on South Asian population, but I want to branch out to different communities in the future to understand how to best support the kids that are home, especially girls and increasingly boys too, who are struggling with self-image concerns because of social media and mindlessly scrolling. And we've all been there. Come on, let's face it. So that is the idea behind that. I don't know if there was anything else that I needed to share, but I'll stop here. And if you have questions, I'm happy to contribute.
Sure. Thanks. Yeah. So that brings us to the next portion. I just have 3 prompts and you might be thinking of the same things, but if not, definitely raise it like after we go over these 3 prompts. So the first is, you heard like from earlier today that the API is a large umbrella. We're under a big tent, but you're starting to hear kind of like flavors from each of the speakers around like the nuances of the populations that they work with. So I want to hear from you, maybe like kind of like tell us more about, what some of you use the word intersectionality, but others are about like, kind of like ethnic, linguistic, religious considerations in your work. So maybe you could just talk about how like you have adapted over time and how that process came to be.
Yeah, it's actually interesting. People would look at me and if I would say I'm Asian, they'd be like, no, you're not, you're Indian. I'm like, okay, so so there's that, right? That we had to sort of navigate over the years. So when people hear the word AAPI, oftentimes they don't think of people from Pakistan, India, Bangladesh, Maldives, and other places like that, right? So that's one thing that I'm also trying to have a better conversation about and dialogue about, that we do fit that category, geographically speaking, right? And otherwise too, because for example, when you hear the word Muslim, you may not think there are Muslims in China, but there are. And so things of that nature, right? I think for me personally, it has been about advocating quite a bit in school systems and with professors, whether it's with students or friends or neighbors or faith leaders or what have you. I think it's that education piece that is very crucial, to help them become aware of who belongs into the AAPI community and what the challenges are. One size does not fit all. So that's another thing that we've been focusing on, that just because you're an AAPI doesn't mean that this particular system or process will work for everyone that fits that category. That is not true. And so I think understanding those nuances has been, of course, integral as we try to ensure that we provide adequate and, supportive environment and safe environment for these populations.
From a policy perspective, I think data disaggregation is kind of where this touches in on, because for the government, they've historically collected, you've probably seen a transition, right? For those of you who follow the census or in the healthcare industry, of course, the Pan-Asian category, and then it started to break up into a few different ethnicities. Now we've been adding Pacific Islander and Native Hawaiian ethnicities. And we continue, as an advocacy organization, we continue to press the federal and state level governments and institutions for data disaggregation, because, like my colleagues have mentioned, the state of mental health and the risk factors in mental health and triggers vary quite vastly by community.
Yeah.
The 2020 pandemic of anti-Asian hate largely impacted East Asians and Southeast Asians like myself. I'm Vietnamese American, who can look East Asian passing, right? People may think that I am East Asian.
Yeah.
And so a lot of the statistics or anecdotes of experiencing discrimination and increased mental health issues due to specifically COVID-19 anti-Asian hate impacts the East and Southeast Asian community. But if you could turn around and you ask the Native Hawaiian community, Pacific Islander community, or South Asian community, those weren't necessarily the triggers. The triggers were perhaps, post-Trump era and now entering issues abroad now. The South Asian community has a different set of triggers for their mental well-being. Native Hawaiian and Pacific Islanders, that community largely is in the front lines of healthcare and service industry. So during the pandemic, their triggers for mental health issues were because their family members, PIs, Pacific Islanders, had among the highest death rates due to COVID-19. Their family members were just passing away like left. I have friends who are Pacific Islanders who were just constantly going to funerals. And so their reasons for needing care and for needing care were much different from like East Asians and Southeast Asians. And so it is super important to disaggregate the data around issues like mental health and depression and substance use, because then that way we're able to direct resources and actually direct, care efforts and access and resources to the communities as they need. So I don't know if Joan has anything to add. Oh, did we lose Joan?
Yeah, I'm here. I'm just not showing on the screen,
Okay.
but can you hear me?
Okay. Joan, did you want to come in?
I'm here. Can you hear me?
Yes. Would you like?
okay.
Yes.
Yeah. So I just had a couple quick thoughts. I echo one of the comments about, for example, Muslim in China. So personally, I have friends who's Muslim in China, right? So, and also I have people here like from immigrants, right, from the same country as myself, being Chinese. So I do echo that, and I also emphasize. I want to emphasize allyship, right? So because we have multiple cultures in this country, and even like we are talking about today's focus is AAPI, but we have a lot of minorities in this country. So in this battle, I think we should not only focus on inside, but also focus, we can have allyship to work on this matter. So those are a couple of quick thoughts I have.
Yeah, that's a good segue to the next item I'd like to bring up, which is stigma. We've heard today about, it being the main challenge in, a lot of ways in which we communicate with one another, but also in terms of treatment seeking. So, can you each comment on how, like, what are, again, like, what are the ways in the different populations you work with, like, like, would you be able to help them overcome the stigma surrounding mental illness?
Yeah, I think for me, when I hear the word stigma, for some reason, I also associate that with shame. So a little bit of story. I moved here when I was 11 years old, and the year that I moved here, 9/11 had happened. Yeah, you can only imagine, right? And I didn't speak English actually at all. And so because my English, the languages that I spoke before English were Hindi, Urdu, and Gujarati. So English is my fourth language, actually. And so comments like "go back to your country," right? And I think for my parents, because we all immigrated here, not having the understanding around what my challenges might be at middle school, they didn't really know where to send me or what support to provide me and my brother. So I think the work around stigma for me has started with my own family, me having to open up a bit more about what my struggles were and how at airports I still get very anxious, right? Because of comments like "go back to your country, you don't belong here," and things of that nature. So I think for me, it's a work in progress till this day. But the work that I do with the communities that I serve, it's not an overnight process. We all know that because we've been struggling with trying to destigmatize mental health for a long time. But it starts with honest conversations, and I think it's for some reason, and for actually good reasons, it does start with parents as well, educating parents, right? Because a lot of the focus has been on youth right now. But youth may be vulnerable and may be honest and open and authentic, but the parents, are they able to receive that, right? Are they willing to have that dialogue and conversation? So when I think of stigma, I am also thinking of shame. I'm also thinking of what kind of vulnerabilities exist for kids and parents around this, and how to better navigate those conversations and increase awareness around what the needs of children are developmentally and what the parents need where they are right now, maybe working two jobs or maybe struggling financially, economically, linguistically, not having access to care, and all the other things that we've been talking about all morning, right?
I have a little bit of a different perspective on this, both personally and through my work in the different API communities as well. As I think I agree with you that a lot of the attention on education on emotional intelligence and giving emotional literacy to the youth so that they know how to express like what is it that they're going through has been focused on the youth, and we need to turn to the parents because on the cultural piece, it's shame, or I think it's also in some Asian cultures, or I know like my father is Vietnamese Buddhist, and for him, like suicidal thoughts, I don't remember how he like works this out in his like logic as a Vietnamese Buddhist, but it's like that you haven't like calmed your mind enough and you just like need to practice calming your mind. And that is not something you can say to a teenager who is having suicidal thoughts. Like that's a potential trigger actually. Right. And it's taken, I have a little sister who's a sophomore in college, and it's taken her and I a lot of work on ourselves, and also trying to do a lot of work in understanding our parents' like logic and thought process to also do that education for them, where I think for some, communities, the adults and elders, you don't actually talk to them about mental health as the issue. You talk about other things like how are you showing love and care and how are you expressing it, like you said. Like you don't name depression or suicide necessarily because and again that goes back to the cultural competency piece. But another story I really want to share because it's stayed with me for the past year is an extended family member of mine died by suicide, and my mom called me and just was really concerned for my little sister because they were about the same age. And she's like, do you think your sister has any thoughts of, suicide or anything like that? And I was like, no. She's like, what about your cousins? Like all of your aunts are, how do we make sure we prevent this? And I was like, look, it's case by case, but I don't know, tell your sisters and cousins to tell their kids that they like say, I love you. Like, that's what I said. And my mom was like, what do you mean say, I love you? What is that gonna do? And I said, that can mean the world to these youth. And I can't explain exactly why either, but it's really easy. It doesn't take much. So you should probably just, if you give advice, just say like they could incorporate saying I love you. And I think simple, like you said, starting these conversations can begin to kind of break down that stigma, especially as unfortunately these cases of mental health and depression are getting closer and closer home for many folks.
Yeah, and they go hand in hand, right? Like cultural competency and overcoming stigma.
Yeah, no, I just had a comment. I know oftentimes when we think about mental health and AAPI or other minority communities, we tend to think of the deficits, right? But I think it's also important to acknowledge how beautiful these cultures are and what are some incredibly strong things that we carry, traditions and values and ethics and morals, right? So I just wanted to point that out as well as we have this conversation, that there's some incredibly great things that I've also learned from my culture too, that I continue to carry on.
Yeah, and those can be part of the strategies. Yeah, Joan?
Yeah, I echo that. Really, I have significant or complicated feelings about the word of stigma, and I really strongly echo that cultural piece could be very protective, but also can be harmful. So, as a psychiatrist myself, I practiced in China and then moved to the United States. So I'm practicing now here also as a psychiatrist. Actually got very commonly asked about the question, what's the difference? So you practice in China and now here. So what's the difference? And the people are just genuinely curious about my experience as a mental health provider, right? So my answer to them is stigma. Because I see here in general, I mean, it's ubiquitously, stigma is everywhere in China and in the United States, of course, but I see less in general here. But in our Asian culture, I see a lot of Asian patients at our Stanford Asian Mental Health Clinic, the SMART Clinic. I still see that quite severe. So I don't have a scale. Maybe this is similar to my past experience in China or less or more, but I see actually as it's hard for me to quantify, but I would say similar in general among the Asian culture here and in China. So one thing I noticed when I practiced in China as a psychiatrist is I don't often see people at their mild or moderate stage of any mental illness. I see those people coming to the clinic or the hospital at their peak time, for example, at their most psychotic time, at the most manic time. So the family was not able to contain them any longer in their family or in the community. So they brought the patients to us, to the clinicians. So at that time, I saw a very, very, very good family support, right? So I rarely see any homeless people. I see people came with their family, sometimes a full of room of family folks being there. What's going on with my daughter? What's going on with my dad, right? We really want them to get better. But on the other side, I just mentioned, I don't get through those patients when they are in their mild or moderate stage. So I wish I could do more at that time, because you may already know that it's probably easier for us to treat them or even to do some prevention, right? So that's really the case, because we got those most severe patients, because before that they were contained in their family and the family view them as a big shame. So it's a big stigma showing there, right? So here I see people in the States, I see a lot of homeless people. I see the family support compared to my experience in China is is loose, but the stigma in general is less severe. But again, like I mentioned, in the Asian families, I still see that can be a severe issue. So as a psychiatrist, I feel like it's my duty to educate them, right? At least we can tell them this is a disorder. This is something we can help, maybe not cure, but we can help elevate the symptoms. We can improve the function of the patients, right? Things like that. So, yeah.
Joan, I want to stay with you because you know, the stigma could be a contributing factor, just like family support in delaying failure and treatment seeking. And you certainly mentioned that. That's why you're seeing cases that are more severe. But tell us more maybe about like the efficacy of clinical intervention and whether they're more efficacious when you know, your patients or their families are more acculturated. So is that a myth, or is there a correlation there?
Yeah, so let me clarify your question. So you were asking the family support and how significant is that to the
Oh,
patient's
sorry.
well-being?
Yeah. Maybe I'll clarify. Is it that the more acculturated the patients and the family, the more efficacious the intervention would be, whether it's clinical, actually, also policy and community-based interventions, right? Like, is it that the more, I mean, like, earlier today we heard about the 4 different types of acculturation, right? But is it that the longer you live in the US, let's say, or other ways in which we measure acculturation, the more they get out of the intervention?
Um, yeah, that's a very interesting question. Yes and no. Because of correlation from acceptance to mental health care perspective, probably yes. Because I see definitely a lot of education around that. And also in general, the culture here is more open to mental health care. Not that stigma doesn't exist here again, right? Like I mentioned, but it's in general more acceptable, while the corporation, let's say, more mature or whatever you want to call that. But I also want to come back to the family support piece, as I misunderstood the question, because I do think family support is such a huge component if we view this as part of the intervention. For example, when I get a new patient, I always talk with the patient first. But in any case, if possible, I would get clutter information from family members, from friends, like from social perspective, right? Clutter information, not only clutter information to get to know the patient better, but also I want to engage as much support I can get for the patient. So you have me as a psychiatrist. I'm here to help you. But if the patient had a great social circle, family members, friends, they can engage, that could be a huge help. So I view that as a very good intervention. So I don't know whether that answered the question. It's kind of,
Oh,
to
yeah,
me, it's
no,
yes and
very
no.
much so.
Yeah.
Yeah. You guys want to come in, or are we okay?
I echo her thoughts.
Okay. All right. Good. Thanks. Okay. So that's our discussion problem. Now we want to hear from you. Like, ask us anything.
Yeah, one of the reasons, I had the privilege of putting together a lot of these folks. I wanted, Anna, can you talk about your AI things that you're doing? That's very fascinating.
Sure. Where do I start? So I've been very interested in learning what's out there in terms of artificial intelligence and providing more access to care for individuals. So there are, of course, startup companies right now trying to figure out how do we leverage this to ensure that patients are connected to care. So there's apps that they're building. There's, interesting designs, right? Large language models and things like that. So my interest actually began because of the health disparity and inadequate care. So started looking into that to understand, could this be a sustainable model first? And what are some regulations around this to ensure that it's safe to use, first of all, where their information will not be compromised? So I'm still in the process of understanding that. I do work for a mental health tech company as a full-time mental health clinician. So I do have the advantage of understanding how do digital lessons like videos and assignments, how are they supporting the patients, and what is the response like in terms of retention and finishing their homework and things of that nature. But when I started to learn a bit more about this, my interest actually peaked around social media because of the apps that are there, right? So TikTok, for example, a lot of adolescents are using TikTok, adults are using TikTok. And so when they're scrolling, what kind of data they're gathering, right? So of course, like what role does the algorithm play in terms of giving them the data? So if I have, let's say if I search up on TikTok, suicidal ideation, right? If I had searched it once, what does a search engine do? What do the algorithms do to give me that, to feed that data back to me? Does it give me better data in terms of supporting me and helping me and, engaging me and helping me get through that? Or does it do the opposite, where it feeds me more data about suicide? So that's some of the research that I'm trying to do right now and focus on. To support adolescents, of course. What I found interesting and actually very alarming, not interesting, alarming, is that if you look at the survey and research, adolescents who use social media more than 3 hours a day are likely to double their risk of depression and anxiety. So when the study was done, they actually found on an average in America, we're using it around 4 hours a day, the adolescents are. So, of course, it's a public health concern. U.S. Surgeon General recently released an advisory around social media use for adolescents. So when I talk to the communities that I serve about mental health, this is definitely one of the topics that does come in automatically, because I think there's just not enough dialogue around this. We talk about mental health, and when we talk about adolescents, social media and technology has to be there. And when we think about holistic wellness, and sometimes it's Eurocentric, right? Where a lot of it is, our textbooks and all the things that we've learned, gotten trained on, has been from a particular perspective, right? Europeans, for example, and studies that I've done here. So culturally responsive care comes into play too, as to how do we ensure that, when I talked about one size does not fit all, what do we do to ensure that these communities are served better? And so all that to say is, to wrap it up, is that I think when we think about wellness, think about occupational wellness, financial wellness, spiritual wellness, physical wellness, mental wellness, digital wellness has got to be one of the things that we talk about.
Yeah, yeah, for sure. Okay, others? Please.
So around the AI portion of it. So large language model, there's been a lot of news about a lot of people who have they've set up these large language models, but they don't actually know how they work. So when groups are doing mental health things, are you guys putting in ethical parameters or things that kind of control or putting sort of guidelines?
Good question. That is above my pay grade, but I wish it wasn't because I don't know enough about it. But in terms of advocacy, I'm doing that work. In terms of getting responses from tech companies where they start to prioritize wellness over profit, because you know, it's a side conversation perhaps, but it is extremely disturbing to see how algorithms work and the data that they feed. I mean, they've got to do better. Correct. Yeah. Yeah.
Yeah.
I mean, they focus on parental controls, right? Like on Snapchat right now, for example, they've modified it and improved it to where the parents have better control around what the kids see, and the kids actually require a password now to connect to friends and all of those things, but kids know the password. So it's not really working out, right? So I mean, yeah, I think we've got a long way to go with this.
Yeah. I actually feel like I mean, this might be provocative, but health education hasn't caught up with the technology. So for instance, like with generative AI, there are many different ways you can like phrase your prompts, right? And so that's incumbent on the user to know how to ask, not just what to ask, right? And then also to be discriminate about the information that comes back. But the scrutiny on the company is like, yeah, like what would be the caveats? Like, and we're starting to see that with OpenAI, for instance. Like sometimes they'll recognize the limitation of the answer and tell you that. So I think there's both the demand and the supply side that kind of requires like, you know, attention.
Yeah, and I think with stakeholders too, I don't think it's just tech companies. I think policymakers need to do better, parents need to do better, school systems need to do better. Conversations need to exist in classrooms about this, right? And so, but to answer your question, I think there's got to be better regulatory things out there for this. They're working on it. They're promising the US population, but I just don't know to what extent and how long it will take.
I can speak it. So actually in our tech policy portfolio, AI and regulation is part of our work, and it's been pulling teeth with the government on this. And because the tech companies are pushing back so hard, and with AI developments, you know, what a good example that I had heard last year was if you search up using AI, like if you ask it, how does a pound of feathers equal a pound of bricks? It should tell you the right answer, but because it's sourcing from information all over the internet and from whatever it's pulling from, one person put out there, they just put it out there into the big World Wide Web or whatever, that a pound of feathers does not equal a pound of bricks. And so then AI started spitting out that a pound of feathers does not equal a pound of bricks. And so that, like, just starting from there, the potential mis and disinformation has been a big concern for advocacy organizations like ours. And tech companies have been pushing back on us, even with, this is not related to AI and medical care from AI in the tech field, but in terms of talking about mental health triggers, mis and disinformation on the internet can be mental health triggers for our community. And tech companies have been pushing back on us saying, what's a capacity issue? We don't have like the capacity to be monitoring and regulating our platforms for mis and disinformation. And so that's where we're trying to press on the government side. Well, then you need to provide some kind of regulation for this.
Have like communication platforms ever come up in those conversations? Because take WeChat, for example. I mean, some of us have been in part of these groups where there's like, it's like so much information that comes across, and you can point to the person who's like putting out that information, but that's a different kind of platform than like, you know, say like TikTok, right? Or Instagram. So have like communication platforms ever come up, like WeChat or Kakao?
Well, Kakao is tough because that's a Korean-owned company and international.
Right.
But I think for advocacy organizations, what we've kind of resorted to is actually forming community-based kind of watch groups. And we try to, as much as possible, have our own volunteers in all the different platforms and community forums as possible to identify sources of mis and disinformation. Because again, every time we keep reporting and we collect reports and we present them at a federal level, at a corporate level to, you know, the tech companies or to, you know, UFC and FCC, like they, you know, it's pulling teeth. They're just like, well, we just don't have the money or capacity. I don't know about that.
Yeah, please.
I know Eurocentric is not always a good thing, but it's interesting to look at different countries around the world, not just Europe, but the European Union, for example, tends to be pretty hardcore, and so
I'm talking about GDPR.
well, yeah.
Yeah.
What is the general data?
Like
Yeah.
yeah.
So and so when the tech companies say we can't do this and we can't do that, right away we should ask, are you doing this anywhere in the world? If you can do it for them, why can't you do it here?
Yeah.
That we're not capable of doing it. Well, turns out you're doing it.
Of course.
Yeah.
Well, and then it comes back to, well, we're not being mandated to here, right? And so that's pulling to the government now.
But at least they can't claim that they're,
Like
Not-
yeah, they're like not knowledgeable. All right, we have a couple more minutes. Anything on your mind? 7 minutes. Okay, thanks. Please. Yeah.
Your policy work. Are you working across groups like with NAACP and like because
Yeah.
a lot of these conferences have a lot of the same issues.
Yeah. Absolutely. So we each have our own channels of advocacy, but then we come together as a coalition. So we partner with NAACP, Historically Black Group, National Urban League, Historically Black Group, LULAC, the Latino group, and UNIDO is also a Latino group. And so yeah, different coalitions, we're putting pressure on all fronts. Yeah.
Maybe we can just break early and like let's try it informally. Yeah,
Oh, yeah.
please, Beverly.
Why do you think there were more girls reporting anti-Asian sentiment than boys?
Joan, why do you think more women were reporting anti-Asian hate incidences than men?
That's a good question. I have the data, but I'm not quite. I think it's a very complicated question to answer the why. From a few perspectives, because from the society perspective, right? So there are some system issues there we can work on, and also in our traditional culture, for example, myself being a Chinese, so usually the female plays a social different role than the males, which usually the males are more predominant, right? So from a cultural perspective, so I don't have a clear answer to that, but I do think it's a complicated question to answer from social society and the system perspective. Yeah, I don't know whether the rest of the panels have other comments.
I think generally for us, we've seen that, I mean, women have been just more emotionally literate. And so therefore, they're more willing and able to report, especially in the Asian American community, whereas men tend to like keep it inside more, don't really want to share it. And so I think that's what, at least anecdotally, what we've seen.
But I was surprised by myself. Here I'm an American-born Chinese, but that Atlanta murder of those suicide therapists hit me very, very hard, and made me feel very vulnerable, actually.
Thanks for sharing. Well, I want to thank my panelists. Like you've been so wonderful today, and I want to thank you for choosing this session and sitting here and enriching our conversation. And I look forward to many more for the rest of the summit. Thanks so much.
Thank you. Thanks, Gordon.
Yeah.